Standard Webster's Dictionary, definition of a traumatic brain injury. Obviously, it's when you hurt your brain, okay, from a traumatic force. And it can lead to a lot of deficits, cognitive, psychosocial. Even if you're doing well after a brain injury, you might have trouble at home with your spouse or your family because of your emotional outcome. But this is a big problem, and this is why 1.7 million people a year in the United States alone. It causes a lot of death and disability, and it's a leading cause of death in young people. So it's something that we need to address. Physiology, pretty basic, common sense. Brain surgery is not that hard, actually. Insider's trade secret. The brain requires oxygen and glucose. It requires food. And how does it get there? The blood gets it there. So perfusion. So if you do not provide the brain with oxygen or glucose in a reasonable amount of time, it can sustain strokes, ischemic death, things of this nature. Intracranial pressure. This is an important topic. If you guys don't remember anything about this talk today, this is an important concept. The Monroe-Kelly doctrine. Your cranium is hard and fixed, okay? It does not move. Only 3 things are supposed to be inside of it: the brain, blood going to the brain, and the spinal fluid that it makes. If something extra decides to come in and participate, all the other things get pushed aside. Where are they going to go? Sometimes there's room, okay? Older folks who have atrophy of their brain neurons and have space to accommodate. But in young folks, middle-aged folks, or older folks with plenty of good brain left, the only place to go is over or out. That's what herniation is. Brain herniation is when important vital structures, important brainstem functions get pressed out of the place that they're supposed to be in. That's herniation. That is what ends up in causing death. So when a neurosurgeon is concerned about high ICPs, we're constantly fighting this battle. We've got to keep the ICPs low, because if we don't, the brain stem will herniate and the patient will pass on. The Monroe-Kelly doctrine. Primary brain injury. We can't do anything about this. This happens on the scene. This happens at the scene of the accident. This happens at the scene of when you get into the car accident, get into a skiing accident, all these things that we've talked about. We cannot do anything about this, unfortunately. It all comes after this, and that's what all of us in this room are trying to do for our patients. It's the secondary brain injury. There are plenty of things we can do afterwards to try our best to help our patients. We need to make sure that our patients don't become hypoxic, hypotensive, that their ICPs are controlled. That's all these phone calls in the middle of the night, right? We all know about this. We got to keep the sugar levels in a fine line. Too low, too high, both are bad. Any other medical or metabolic disturbances, and then of course seizures. These are all things that we can try to treat. Treatable things. The first thing, it happened. Boom, I hit the windshield. The second thing, we can try to do our best. Now we're going to talk about guidelines. Obviously, as everybody knows, guidelines change. They get updated. In the past about 20 years, they've been updated 4 times. We learn new things. We do new studies. We're going to talk about that. The point of guidelines on a national level is that there is some kind of standard of care, okay? Things that we know help, things that we think help, things that we can control. This is a joint project. All of the experts, think tanks, fine minds, we're all coming together, and we try to make sure that it's as honed in as possible. Things that we can actually do in the ICU for all you ICU nurses, all you ED nurses, all you OR nurses that are dealing with all these patients who are crashing. What do I do? This is a slide that demonstrates the quality of evidence in medicine studies. It is very difficult to achieve a Class 1 evidence grade. And in neurosurgery, it's incredibly difficult because if you were the patient that came into the emergency department with a brain hemorrhage that I thought needed surgery, and I said, let me talk to your family and decide if they would like you to be in a study. You are dying. How am I going to do that ethically? So it's hard to get Class 1 evidence. So we do rely on a lot of Class 2, 3, and 4 evidence and expert opinion. So keep that in mind. This is a slide that is just basically demonstrating that we're trying to continually improve our guidelines. These are some of the items that we're going to be discussing today. The surgical and medical ICU management of traumatic brain injured patients. The asterisks and stars indicate things that have changed since the last guidelines were printed approximately 5 years ago. All right, hemicraniectomy. Nancy, I'll see you back there. You've seen a lot of these, right? So there is some pretty good data on craniectomy. Level 2A. I mean, that's pretty good. It's not level 1, but it's level 2. The point of this study is that doing both sides is not indicated. You can pick one side and you're probably going to save someone's life. I usually pick the left side if I have a choice, because usually that's the dominant brain hemisphere that controls speech in most humans. If there's a hematoma on the right side, then I'm definitely going to do the right side. Decompressive hemicrania does sometimes save lives, okay? But that's not all we're here to talk about. This is the rescue trial. It showed this. It took a whole bunch of patients, about 400, and they divided them almost equally, 200 and 200. They put them through medical management first. All the steps. Eric, put them on mannitol. Mike, put them on 3%, right? All of the things that we do for these people. Hyperventilate, head a bed up, all of these things. Put them through the pipeline, even barbiturate coma, right? Put them through the whole medical gambit, and then if they're still high, you split them into two groups. You take them to surgery, or you keep doing what you're doing. This is what happened. People will survive decompressive hemicraniectomy and live and have a life, but they will be put into a vegetative coma more times than if you put them through the medical arm. So you're saving a life, but you may be increasing the possibility they're not having a very good quality of life. I mean, that's the hard reality of it, and we've all seen it. So again, you get better ICP control, you get less morbidity and mortality, but you get higher rates of people that are not doing well long term. So then we can have a whole conversation about how beneficial that is, but that's what the data shows. They did and here you see it here. Look at this. This is medical group. How many more people passed? This many. But the people that survived have better quality of life. You're not changing that for anybody. You're giving them a chance to live, but you're probably increasing the amount of people that survive with poor quality of life. Let's talk about what freezing people does, making them cold. So initially we thought once you have a traumatic brain injury, you should be cooled. This new data, these new outcomes from 2016 show the opposite. You ought not do that. Afterwards, we don't know. And usually all of us try to put cooling blankets on, keep our patients cold, keep the ICPs lower, and that's probably the right thing to do in my opinion. But what this shows is that initially, that's not going to help you much. All right, mannitol and 3%. We use it all the time. Mannitol is great for I'm in the ED, my pupil's blown, and I got to go to surgery right now. Hypertonic saline, in my opinion, is better for, I'm in the ICU, I'm vented, I've got ICP problems, and I'm going to be sitting here for a while, and I need something to reduce my ICP. So what I do is I use mannitol sparingly. The old pattern was to give mannitol every 6 hours, and some surgeons, I'm sure, still do that. I am not doing that myself, and I'm not going to do that because mannitol creates this rebound effect where it's a sugar, so it gets accumulated into your brain tissue, and then in a paradox, it draws fluid into the brain tissue and increases ICP if you use it over and over. On the other hand, 3% saline stays in the bloodstream and draws water out of the brain into the bloodstream and probably helps, and it increases your perfusion, it keeps up your blood pressure, you can titrate it, it's my choice. And then we can get to the argument of, well, do we give a bolus, do we give a continuous drip? But bottom line is, take home point is, unless a doctor or a PA who is qualified to give you instructions, mannitol is for acute emergencies and 3% is for maintenance. This is basically a slide that demonstrates the same thing. CSF drainage, level 3. Not quite sure why it's that low, but we all know a ventriculostomy is important in certain situations. Now, whether or not it should be placed should be left at the discretion of the neurosurgeon. But it's important not just for drainage of spinal fluid, it's important for ICP control and monitoring. We need to know what that ICP is. It's very critical. Ventilation strategies. Hyperventilation. Everybody thinks somebody should be hyperventilated all the time and constantly. This is not true. They should not be. This is another temporizing measure. When you are rushing from the emergency room to the operating room, you back ventilate someone and hyperventilate them. That is helpful. When they're sitting in the ICU and be constantly hyperventilated, that is not going to help them. In fact, that can create secondary injury to the brain. It can cause strokes. Anesthetic, analgesic, and sedatives. So, burst suppression. We do it sometimes. If you have no other choice, this is what we do, and this is why. It puts the brain into a state of almost no neural activity, which means it's not delivering as much blood, it's not delivering as much oxygen, or delivering as much glucose. That decreases the ICP because the metabolic activity has been decreased. So I do it for people that have ICP problems who either this is their last chance before surgery, which is the same that the study I showed earlier showed, or I do it if there's no surgical options. I will go to a barbiturate coma if able. One of the issues is that getting an EEG, you're supposed to put patients into burst suppression. We don't necessarily have that at our hospitals, but honestly, rather than getting a craniectomy, sometimes this is a good choice, and it does work to help patients get their ICPs down. Steroids, all right, so this is the only level 1 evidence we have in neurosurgery, honestly, of that you should not do this. When people ask me, when anesthesia asks me, do you want me to give steroids for traumatic brain injury? The answer is always no, because it doesn't help, and it just sets your patient up for side effects, pneumonia, infection, all of these things. It is not indicated. Everybody hear this. There was something called the CRASH trial. This is never give somebody with blunt head trauma steroids, ever. Nutrition, obviously important, common sense, we all know about it. Starting tube feeds early, starting trickle tube feeds, things like that. It's a good thing to do if you don't think they're going to go back to surgery for some reason. For orthopedic injuries, all that, in trauma, everybody has multiple injuries sometimes. But getting the nutrition started and getting it started early as possible, no later than 5 to 7 days, is important. Infectious prophylaxis. Early tracheostomy, good topic to talk about. I believe that we should do it sooner than later if we think the patient is going to be debilitated for a long period of time and the family thinks that they would want to give life or quality of life a shot. I usually say about 7 days. The data would support that. But it's very important, and that's why all these conversations we have with our patients, always, what do they want? What does their advanced directive say? What were their wishes? I mean, having these family conversations, obviously, as you all know, is hard, it's complicated, it sometimes can be painful. There's 30 people in there that all want to know what's going on. But things like this are so important. If this patient is alive and has survived, we need to talk about the family about what's going to come next. We've got to have our eyes looking forward. I would put a trach in a peg in somebody 7 days after their injury if they're young and their family wants to give them a shot. As they get older, that gets harder. Dvt prophylaxis, again, a lot of surgeons are worried about this causing increased hemorrhage, having to go back to the operating room, this, that, and the other. This is level 3 data. We don't, that's almost anecdotal data. I typically try to use a Dvt prophylaxis mechanism immediately in terms of mechanical, but within 48 hours in terms of chemical. So if my patient, even if they have a very bad contusion, if you call me 48 hours later and their CAT scan is stable, I will give them subcu heparin, because DVTs, which lead to PEs in a patient who's laying in bed in the ICU, can completely screw up everything we've been trying to accomplish. And I don't believe that they result in extra complications. However, blood pressure is important. If you think about blood pressure of 200 riding through a small arteriole, that could create a tiny bleed that gets to a bigger bleed, that gets to a bigger bleed, and while on subcu heparin, that could create a massive bleed. So if we're going to put them on Dvt prophylaxis after a head injury, we've got to have good blood pressure control. Seizure prophylaxis, we know it works. Use it for 7 days. Using it after that might not work. Do it if you want. I try to get them off of it as soon as possible. I use Keppra because you don't have to check levels. It's a standard dosing strategy. The problem with Keppra is that it creates depression, blunted emotions, a lot of front lobe symptoms. People hate it. They complain all the time. Dilantin works fine too. All the studies have been done with Dilantin. The problem is that you have to check levels because it can become toxic if they're too high. Bottom line is, as I think you guys have seen and know, we use Keppra most often, unless there's an allergy or something, and then we use Dilantin or fisphonitone, which is its basically cousin. But it's good for 7 days. Icp monitoring, again, we do it all the time. It's probably helpful in certain situations. If we didn't do it in every case, outcomes might not change, and there are studies that show that. But therefore, we leave it up to the choice of the surgeon, the critical care doctor, the trauma surgeon, whether or not it is required based on the patient's physical exam, Glasgow Coma score, severity of injury on a radiograph. It's case-by-case basis, but it's probably helpful. Same with CPP monitoring. It's level 2B data. It's pretty good. I mean, we don't always consider that, but we probably should. It's one thing for a patient's ICP to be 30. It's another thing for their ICP to be 30 and their MAP, their mean arterial pressure, to be 70. That means they're getting a cerebral perfusion pressure of 40. That's not acceptable. So when you're thinking about CPP, it's a very simple equation. It's your MAP minus your ICP, and that's your number. So always think about not just the ICP, but what's the blood pressure doing. That is the one thing that nurses can do to impact patient outcomes. Always pay attention to the blood pressure. This is some more advanced technology. I've actually never used this, not in training, not here. I'm not so certain on it yet, but brain perfusion, brain oxygen concentration is a newer technology that folks are looking into. In my personal experience, when we tried it as a trial one time in my residency, what leads to problems is that you just keep flooding patients with fluid. That is not a great thing to do, because then, your tissues get swollen, right? We all see it. This patient looks fat, swollen, legs pitting edema. I mean, think about what their brain looks like. If you got to be mindful of ins and outs and how much fluid we give patients. Don't overload them. Their brain will become overloaded. Then your ICPs are high. Then you're circling the drain. Then you're wondering what to do next. Blood pressure thresholds, again, like I said, blood pressure is so important with head trauma. Can't be too low, can't be too high. Depends if they have an intracranial hemorrhage. Either way, just don't let it be too low. And when it gets too high, call for help. We will help you. We've got to keep it in a good range. This is very basic. Everyone in this room knows this. When the ICP is high, please call for help. We got to treat this. We can't let this linger. Same with cerebral perfusion. We just talked about that. These are the advanced techniques we just talked about. So there's no hardcore, very good evidence about any of this right now. It requires different monitors with different electrodes, and this is an academic level right now. It's not proven. We're not deviating from the standard of care by not doing this. This is something that actually might not pan out to be very helpful, but just know that it's out there right now. Take home point is keep the ICP and the blood pressure in mind. Talk quickly about the different kinds of brain hematomas. Okay, there's an intraparenchymal, that means inside of the brain tissue. There is a subdural, that means outside of the brain, but under the dura mater. And there's an epidural hematoma, which is outside of the brain, but over the dura mater. These can be dangerous if not treated quickly. Epidural usually comes from bleeding of the middle meningeal artery. If that happens, massive bleeding quickly. Usually you hit a tree, it hurts, you're stunned, you wake up all of a sudden, and then you decline again. This is probably the why people say don't let someone go to sleep while they're having a concussion, because these are the ones that can result in rapid death. In reality, if someone has just a concussion without this problem, they need to rest. But an epidural hematoma is a surgical emergency and needs to be treated very, very quickly. A subdural is a different animal. If it is acute, car accident, skiing accident, what have you, and there is a huge hematoma with brain compression and a poor neurologic exam, it's an emergency. If it is small or if it is chronic, that is a different story. The patient's awake and alert. That is what requires a neurosurgeon's skill or a neurosurgical physician assistant skill to determine they're doing okay, they need surgery, they don't need surgery, let's watch them. There's a whole bunch of categories there. Again, epidural hematomas, as we talked about, these can or cannot be very critically emergent. Most of a neurosurgery is based on someone's physical exam. The scan is important. It's part of the puzzle. But the exam is the most critical part of neurosurgery. Doing an accurate exam, all of you guys learning how to check a patient's exam, learning the Glasgow Coma Scale, checking the pupils, learning what posturing looks like, extensor, flexor. All of that is so critically important for emergency room doctors, trauma surgeons, and ICU nurses, ED nurses, operating room nurses. If that is just, I cannot harp on that enough, how critical the exam is. Whatever the radiologist says about the scan, meaningless. The exam is everything. Subdural hematoma, again, outside of the brain, under the skull, under the dura mater. Looks like a loon, a moon. They call it semilunar because it's got that crescent moon shape. This is one of the most common reasons why we get called. And honestly, again, if it's acute, the patient is looking horrible, it's big, there's shift, high ICPs, that's surgical. If it's small, subacute, chronic, it requires our expertise to determine. But as long as the patient is awake and alert, we're doing okay. Here's a little bit of technical, terminology about how we classify a subdural hematoma: acute, less than 72 hours, subacute, 3 to 7 days, and chronic, greater than 21 days. We have all seen all of these. And one of the interesting points about this is the color of the blood. So when on a CAT scan, and this does not mean MRI, we call this hyperdense because it looks like the bone next to it. That's acute. You can't really see it here because that's called isodense. It looks like the brain itself. Here it's called hypodense because it looks black and you can distinguish it from the brain. That's how we know how old it is. Picture of the brain. Carl, have you ever seen that? Another one. Acute subdurals. I don't know if I necessarily agree with this first statement. An acute subdural with a thickness greater than 10 millimeters or a midline shift greater than 5 should be surgically evacuated. That still, in my mind, despite the guidelines that have been created, is up to the clinician in charge of the patient. There are plenty of people who have brain atrophy, plenty of room in their head. The Monroe-Kelly doctrine that we talked about, how much space do you have in your head? There's plenty of people that come into our hospital with a very large acute subdural who are just chilling, sitting in the ED, eating their sandwich, and we don't operate on them. So it's a good rule of thumb, but it's not a definite in my mind. Timing, of course, we all know this, and all of us, I believe, have done a very good job of this. Once you recognize a surgical patient, you do not do anything else except focus on getting them to the operating room. If me or Andy or any of our partners come in and say, let's get this guy to surgery, let's just get him to surgery. There's nothing else that we should be doing at that time. If we don't have an operating room, that needs to be communicated so we can try to figure out a different strategy. There's lots of future studies we can do. Like I said, it's really hard to do studies in neurosurgery because you're basically taking a patient who's on death's doorstep and saying, well, I'm either going to put you in a medical or a surgical stratification. That's ethically questionable, but we can always do retrospective studies and things. That's why most of the data presented today is either level 2, 3, or 4. Parenchymal lesions, again, questionable. If they're very large and surgically accessible, I may try to evacuate them. It may help the patient, it may not. There are studies that differ on this. Some of them say it doesn't do a lick, some of them say it doesn't. So I usually wait until the patient is very somnolent or obtundant before I would operate on these, unless it's in an area that I think would be easily and successfully surgically accessed. Posterior fossa masses. Posterior fossa is an important part of the brain. Anything in the posterior fossa should not be there. If you have to operate on this, you should immediately. Most of the time, trauma does not involve this compartment of the brain, but if it does, do not mess around. Go right away. Cranial fractures, most of them are non-displaced and don't need surgery. When they become depressed, they should be immediately addressed and repaired.